Welcome everyone. Good morning in Europe time and good evening in Asia time. Thank you very much for joining this webinar, which is the fifth webinar of the Tokyo WAF 2023 series. Today we have a good and a very interesting topic of tricuspid WAF from diagnosis to repair and Asian perspective. The learning objectives of today's webinar first is to learn the anatomy and physiology, specifically to Asian population. Second is to understand the patient selection criteria, especially for the imaging aspect for TriClip. Third is to learn the basic procedural steps for transcatheter edge-to-edge repair with TriClip. So we all know that tricuspid valve is a very important valve, but the challenge is, first, it is usually the last valve to be treated. Secondly, even for surgery, it also have a lot of challenge. And third, even for transcatheter heart valve, it's very difficult. So most importantly, today we are going to learn how it could benefit our patient, especially in our Asian population, and how to select the most appropriate patient for the procedure. Today, the format will be there will be a live or recorded case about a tricuspid repair, and in between we will have some background slides telling you about the basics, for example, the anatomy, physiology, imaging, acquisition, and how to assess a patient and post-operative care. So first, I would like to start off with tricuspid anatomy and pathophysiology Asian perspective. And most importantly, before going into that, today we have a good team to bring this webinar to you. First, I'm Simon from Hong Kong. We have Dr. Hayashida from Japan, and we have Dr. Izumo, and also we have Dr. Francesco Mazzano with us. And also we have, importantly, we have a chat function, and we have a chat master, Dr. Sunsuke Kubo, to help us with the chat function. And please be interactive and tell us what you think, and you can feel free to give your comments and questions. First, I will go to the slides. So we know about the tricuspid valve is the most apical and anteriorly positioned valve. The normal orifice area is around 7 to 9 centimeters square. The mean gradient is below 2. Typically, it composes of 3 leaflets of unequal sides, but not uncommonly, we encounter 2 or 4 for our patients. So the anterior leaflets typically will be the largest in area, longest in radial direction, and with the greatest motion. Posterior leaflets is shortest circumferentially, may have more than one scallop. Septal leaflet is least mobile because the manicordia attached. It attached to the annulus directly above the IVS, and septal posterior commissure is near ostium of the coronary sinus. A lot of papillary muscles and moderated bands. Anterior papillary muscle is the largest, supplies the AL and PL. Posterior papillary muscle supplies the PL and SL. Septal papillary muscle is more multiple or absent, and as I mentioned, they're moderated bands. So when we're doing the procedure, we have to avoid entrapment into those trabeculations or the tandy. So a normal annulus is saddle-shaped, and a high-low distance around 70 millimeter and elliptical. Annulus will become more planar with high-low distance smaller than 4 millimeter and circular as it dilates. In left heart disease with sinus rhythm, dilatation occurs primarily in the anterolateral free wall, and in chronic AF and functional TL, dilatation occurs more in the posterior border based on the CT or 3D echo studies. Tricuspid regurgitation, the primary and secondary pathophysiology, and most of the time, 80 to 90% will be functional in nature. Primary causes include congenital, including S-time anomaly, myxomatous degeneration, rheumatic, infective cause like infective meningitis, traumatic induced by lead or endomyocardial biopsy. Second, most importantly or most commonly be related to left side disease, primary hypertension, airway dysfunction, other types of other congenital heart disease, chronic atrial fibrillation. So for Asia, it's no difference from the Western world, but we have patients population big because we are the life expectancy is a bit long in Asian population. The pathophysiology is similar, but we, myself in Hong Kong, encounter a lot of other congenital heart disease patients. They have operation before in a young age, so it's good for a transcatheter option for them, and also patients with dilated cardiomyopathy or with pacemaker leads. Anatomically, and technical aspects, we in general have a smaller heart. Sometimes when we handle the catheters, there may be technical difficulties, and management option, patient selections, will be also important in Asian population. So we know the lateral cause of TR we have to treat, but the operative mortality is isolated TV surgery is high, and so we have important scores and criteria to guide us for intervention. And last slide is about how we're going to treat the patient with triclip. We establish a tissue bridge to help with the coaptation, and a similar way to reconstruct the tricuspid valve to improve the insufficiency. So next, we pass the time to Dr. Izumo to tell us about patient selection for the procedure.
Yes, thank you, Simon. Thank you very much for the opportunity to discuss about patient selection for tricuspid H2H repair. This is my disclosures. So, okay, these two devices are the main types of tricuspid H2H repair in the world, and only the triclip is undergoing clinical trial in Japan. So time is limited. So I have listed 3 important parameters for patient selection here: septolateral gap, the number of leaflets, and jet location. So the short axis images of the tricuspid valve by the transgastric view is important in this procedure. And the measurement of septolateral gap, so-called coaptation gap, is important for patient selection. When the coaptation gap is over the 6.5 millimeters, it is very difficult to grasp the leaflet and one of the predictors for procedure failure. The number of leaflet is important for patient selection. A tricuspid valve does not always have tricuspid leaflet. It was very impressive because I thought the tricuspid valve was a tricuspid leaflet before the introduction of the triclip. Dr. Han investigated the number of leaflets and reported that about 40% of TL patients have quadricuspid valve for leaflets. The number of leaflets also influences procedure results. Dr. Sugiura reported that more than 1/4 patient who performed H2H repair had 4 leaflets. They have grade 3 or more residual TL than patient with 3 leaflets. The position of the pacemaker lead is also important for patient selection. 3D echo is useful to determine the position of the lead. Left panel shows the lead position between the septal and posterior leaflet, preserving the mobility of leaflet. It is a good position. But the right panel shows the lead pushing the septal leaflet and a large gap. So 45% patient of the primary mode show device lead to tricuspid valve lead induced regurgitation. The septal leaflet was the most commonly affected. The origin of the regurgitation jet is important for H2H repair, and 3D echo is useful to determine the location of the jet. It is relatively easy if the jet is located along the septal leaflet, but difficult it is found at the anterior and posterior leaflet. In this talk, I have discussed 3 important aspects of patient selection, but we must not forget about the image quality of the echo. Echo images are key to the success of this procedure. Thank you very much for your attention.
Thank you very much, Dr. Izumo. So next will be the part 1 of the recorded live case prepared by Dr. Mazzano on a patient with severe TR receiving a tricuspid H2H repair.
Yes.
So let's start with the case presentation.
We are going to use a Generation 4 tri-clip, so I would like to briefly introduce you to the modified system. The clip delivery system has only one flexion, only one steering position, which is flex and extension. Flexion obviously flexes towards the clip, towards the tricuspid. I can show you by maneuvering in RAO. If you look at the fluoro, if I release the flex, if I extend, it's extending. If I flex, it flexes towards the tricuspid. This is the only maneuver that we have on the clip delivery system, while the main maneuvering to get coaxiality is done with the improved tri-clip guiding catheter, which has basically two knobs. One is a plus-minus knob. If you apply minus, if you apply minus, you basically bring the system away from the tricuspid. If you apply plus, you bring the system towards the tricuspid. This is in this particular patient today. We don't have too much problems with height, but actually it was a problem with an off-label mitral clip system. Also, it's shorter the length of the CDS, so the CDS doesn't go too much forward, and so it's the problem of falling into the tricuspid is less of an issue here. Finally, and not a secondary issue, is the septolateral knob, which is adjusting for the discrepancy between the line of the inferior vena cava and the center of the tricuspid valve. So these are the features. On top of that, we are using a G4 clip, Generation 4, meaning that we have the 4 sizes. We have XT, XT wide, NT, NT wide, and independent grasping, which are really making this procedure more straightforward, a little bit more standardized, more controllable, and in our practice now it becomes to be very controlled. And I would like to ask Eustachio Agricola to show us some images of this particular patient, starting, you see now a transgastric view. Eustachio?
Okay, thank you, Francesco. Let me describe the anatomical features of this valve, tricuspid valve. This valve has 4 leaflets, posterior, septal, anterior, and another portion of the anterior leaflets that is separated by a cleft. So the quality of imaging is good. We have good transgastric view, but also we have good mid-esophageal view. The main mechanism of regurgitation is annular dilatation. Probably this patient has an iatrogenic tricuspid regurgitation associated with the billowing of the tricuspid leaflets. So the jet originates mainly from the central part of the valve. You can see this is a transgastric short axis view, mainly central part of the valve, but also we have commisural components of the jet, so jet also come from anteroseptal and posteroseptal commissure. So there is no tethering of the valve. So we have big annular dilatation. The septolateral diameter is 48 millimeters. So I think we can go with the procedure.
Thank you, Dr. Mazzano, showing us the first part of the case, including the manipulation of the device and the image. But then, most importantly, before the procedure, patient selection is very important. So, Dr. Hayashida, we're going to tell us about some of the base background of this patient and how to guide our decision-making process. So, may I pass the time to Dr. Hayashida?
Yep. Thank you very much, Simon. So I'd like to introduce the case presentation. And the case is 80 years old male who has the 153 centimeter and 62 kilograms. And he also had the risk factors for the hypertension and diabetes mellitus. And he received the mechanical valve mitral valve replacement in 2000. He also had paroxysmal atrial fibrillation, and he suffered from the admission for the right heart failure due to severe TR. He also presented the dyspnea, abdominal distension, and mild peripheral edema with NIH class 3 heart failure. And laboratory demonstrated the hemoglobin to be the 11, and renal function should be okay, and total bilirubin was 1.5. And he also received furosemide, carvedilol, amlodipine, warfarin, and metformin. And if we calculate the tri-score, that is a risk score for the patient with TR, and the risk should be age, NIH class, right third heart failure, and elevated total bilirubin. That means the 6 to be the 22% in hospital mortality after a surgical procedure. And I would like to hand over to Masaki for the presentation for the echocardiography.
Thank you very much, Hashida. By quantitative analysis, so I would like to say it's moderate to severe tricuspid regurgitation, but visual assessment and the reversal hepatic vein flow indicate a severe TL. And also there were no degenerative changes of the tricuspid valve, so etiology of this case is confirmed secondary TL. And transgastric view is also great image quality. And before the video, this image that image shows the full leaflet. And the posterior leaflet might be separated, and the regurgitant jet were located not only lateral position but also anterior posterior leaflet position. And then I think this case is not easy case. Next slide, please. Okay, next slide. Okay, here, transgastric view here. Okay, thank you. Next slide. Okay. Furthermore, this case has pulmonary hypertension and mildly reduced right ventricular function. So I think this case is high risk for isolated tricuspid valve surgery. Thank you.
Thank you very much. Thank you very much. And it brings up an important point. So we need some objective parameters to assess our patient and guide the decision process for physicians. And it was included in analysis with the tri-score. So can Dr. Izumu tell us more about the tri-score? And Dr. Mazzano, it seems to be a very new concept to us. And can you tell us more about that?
Thank you. Tri-score is a new risk score for predicting in-hospital mortality for isolated tricuspid valve surgery. This score was reported by multicenter registry in France this year. So most of the isolated TL patients are elderly, and TL is associated with organ failure as well as right ventricular dysfunction. So this is totally different from the left-sided valvular heart disease. So tri-score focuses on the parameters such as right ventricular dysfunction, total bilirubin level, diuretics use, and CKD. So at this score, patients with a score of 4 or higher have a mortality rate greater than about 10%. I think it's a very useful score for decision making. Thank you.
Yeah, and it is the first score which has been specifically designed for tricuspid, because you can imagine that the cases are very limited. So STS and Euroscore are not really designed for these particular patients. And I think it's an important score also because as we focus more on tricuspid interventions, we see patients now are earlier indicated. And so in these patients, you should really take care of the comparative risk between surgery and a transcatheter intervention. Still, we need to learn if the tri-score is also applicable to patients undergoing TriClip or other transcatheter interventions, and they are working on process on this topic. But I think it's a good tool to take decisions.
Yeah, thank you very much for your advice, Dr. Pisano. And now we'd like to learn more from you and recap from what which has been shown on the video, the basic manipulation steps for the TriClip device.
Yeah, so as you have seen, the delivery system has been upgraded to be used in the tricuspid space. We have been using MitraClip delivery systems in the past, off-label use for treating tricuspid regurgitation. And there were several limitations. The two main limitations have been the tendency of the delivery system to fall into the tricuspid annulus. And this has been solved with the plus-minus knob, which is the knob which is actually bringing the delivery system away from the annulus. But the most important, in my opinion, adjustment has been the septolateral knob. This knob is basically bending the delivery system at the level of the inferior vena cava anteriorly, or let's say laterally, in the direction of the lateral wall, to allow a much better coaxiality. Lack of coaxiality overall is the main reason for failure in edge-to-edge repair, both in mitral and tricuspid. Tricuspid is actually much more difficult because of imaging limitations we will see very soon in the case, but also because of the complexity of the anatomy. As you have seen, this particular patient is a not uncommon patient with 4 leaflets configuration. But even in a 3-leaflet configuration, the line of coaptation, different from mitral, which is only one line, is a semicircular line. In this case, it's like a Mercedes-Benz, is a 3-line configuration if there are 3 leaflets, and is a 4-line configuration if it is a 4 leaflet. So it is actually much more difficult to find the ideal spot for the clip implantation. And for this reason, you need a very reliable delivery system, which is very solid and very reliable in bringing you exactly where you want. Actually, I suggest everybody not only to work on coaxiality, but also to stop ventilation as you cross the leaflets to enhance precision. So in this slide, you can see that there are some different technologies which are applied now in the TriClip G4. Obviously, one of the advantages is the independent grasping. I have to admit that independent grasping has always been a double-edged sword, because on one side it allows you to tackle more complex anatomies. On the other hand, it exposes the patients to 2 risks. One is distortion, and one, even if you're very careful in avoiding distortions, you still pull a lot of force on leaflets, and therefore we have seen in some cases issue with leaflet ruptures. Actually happened to me only 2 days ago, where I had an anterior leaflet tear and I had to close it with an unplatzer, which actually in the right side works much better than the left side because you have much lower pressures. But still, word of caution about independent grasping because of the many limitations. So again, the first approach usually is always concomitant grasping. The other point about the TriClip G4 is that you have a wide variety of clip sizes. But to be honest, in the tricuspid space, we almost invariably use the XTW configuration because, first of all, because most of these patients have a coaptation gap, so you need longer clip arms. But also, whenever you use longer clip arms, you like to have wider configuration, which is distributing the forces and is reducing the risk of leaflet tear, providing that actually the tricuspid valve has usually very large anatomy, so the risk of creating a stenotic valve is pretty low in these patients. Now, we have seen this already. I mean, this new technology is actually bringing a number of advantages. And I want to, again, reinforce the concept that the main advantage of the TriClip delivery system is the ability of being coaxial to the line of coaptation, coaxial to the long axis of the right ventricle, and precise into the line of coaptation. You really need to be able to navigate, as you can see in this animation, in the line of coaptations. The typical approach is to start with the anteroseptal clip implantation, but obviously in many patients today, we are performing clip implantation both in the anteroseptal and in the posteroseptal in the so-called Clover approach, because in this way you obtain much better outcomes in terms of reduction of the TR, also not only because you are joining leaflets, but also because you have a much stronger effect on annular reduction.
Thank you very much, Jose Mazzano. And sometimes at the very beginning, it's very difficult to remember the notes. But then once you do more case, then everything become automatic. And also one challenge is how to orientate ourselves looking at the echoes, because sometimes confusing because different views, and how to assess the severity of a TR. And Dr. Izumo is going to tell us more about the image guidance for the procedure.
Yes, thank you very much. Okay. Okay, I'd like to talk about the imaging basics for TR assessment and TEE guidance for TriClip. This is my disclosures. So, okay. With the introduction of tricuspid HTH repair, the assessment of echo in tricuspid regurgitation has changed significantly. In this session, I would like to focus on the severity and morphological assessment. So assessing the severity of TR remains challenging, but really important. With the introduction of catheter devices, a new grading has been proposed with extent to the severe to massive and torrential like this. This new severity classification also has prognostic implications. This study reported that patients with massive or torrential TR had a significantly higher rate of cardiovascular mortality and heart failure hospitalization compared with severe TR. Dr. Hahn and colleagues present a new quantitative assessment of TR severity. Three main echo parameters are used, and I would like to discuss about two parameters, vena contractor width and 3D vena contractor area in this talk. Angular enlargement is an important factor in the mechanism of secondary TR. Dilatation of the annulus toward the LV free wall. Therefore, the regurgitant jet is often found along the septal leaflet. The septal leaflet and anterior-posterior leaflet must be grasped to get reverse remodeling by H2H repair. Vena contractor width can easily be measured with good reproducibility. It is recommended to determine the average of these two images. When using the vena contractor width, we can assess surrogate for regurgitant orifice size. 3D color Doppler is useful to assess not only the jet location, but also severity of TR. 3D color Doppler can directly measure the regurgitant area. Vena contractor area is measured by reconstructing the 3D image. So it is sometimes difficult to determine the location of the blue line like here, but this can be made easier by using a color suppressed image as shown on the right panel here. Next topic is about morphological assessment. Etiology of TR is important for decision making. More than 90% of TR cases are secondary TR. Most secondary TR is associated with left-sided valvular heart disease. About 20% of secondary TR is idiopathic. I think possibly atrial functional TR. 3D echo is an essential image modality in the morphological assessment of the tricuspid valve. The general rule for guiding the edge-to-edge repair is that 3D echo should depict the aortic valve at 11 o'clock, like this, and septal leaflet at left side, as shown here. The anterior papillary muscle is important to separate the anterior and posterior leaflet, as Dr. Simon said. The diagnosis of the anterior and posterior leaflet is sometimes difficult, but can be made easier by using 3D echo to show the anterior papillary muscle like this. Of course, 3D assessment is also important. The tricuspid valve is assessed from 3 main angles, the same as the mitral valve. It is important to understand where the image displayed at each angle shows the tricuspid valve. RV inflow-outflow view is important for tricuspid valve assessment, especially for guiding the triclip. But deep esophageal view can show the clear tricuspid valve than the middle esophageal view. The image quality of 3D echo can be particularly remarkable. In the middle esophageal view, the echo beam is blocked by the atrial septum before the tricuspid valve, whereas but echo beam directly reached the tricuspid valve in the deep esophageal view, like the mitral valve, like this. We can get the clear tricuspid valve images by trans-illumination rendering through view. This technique is useful to understand the tricuspid valve morphology easily. The LV inflow-outflow flow with X-plane images is one of the most important images to guide the catheter. We can get the LV inflow-outflow and the long axis image simultaneously to guide the position of the catheter. LV inflow-outflow images shows the anterior and posterior leaflet side, while the long axis images show the septolateral side. A short axis image with the transgastric view is also important and is essential for determining the position of the catheter and whether the valve leaflet can be grasped. In summary, ladies and gentlemen, with the introduction of catheter treatment, the severity of TR has been newly classified, which is also useful in predicting prognosis. 3D assessment of the tricuspid valve has become essential, as well as new 3D echo assessment, such as transgastric view. Echo image quality is also key to successful catheter edge-to-edge repair. Thank you very much.
Thank you very much, Dr. Mazzano and Dr. Izumo. And we know now we need to select the correct patient, and we need to know how to interpret the image and bring the patient to the cath lab, and we need to know how to manipulate the device. So the next part will be the second part of the video with Dr. Mazzano showing us how to put in the clip, what is the decision-making process during the procedure. And now let's go to the second part of the record case.
I think it's the right time to open the clip arms and see how they open. Actually, we are opening in the wrong direction, but we can control immediately. Okay, we like to see no clip arms in the inflow outflow and to see the clip arms in the other projection, which is what we see now. And I would like now to test the gripper. So this is an important step for the G4. We can identify the septal gripper from the anterior gripper. So let's see, I move. This is going to be the anterior, as you can see here. And this is going to be the posterior, the septal. So the septal is the one with the dot. And now we'll put them together again. All right. So let's go, and I think without further discussion, because maybe we need to put two clips, let's start here. I see no much movement with respiration, so I would probably move like this. I will close slightly the clip arms to have less interaction with the leaflets. Okay, I try to be in the middle of the valve. Let's go transgastric view, because this is very, for precision, I think we had a fantastic transgastric. So I would like, I'm a still old-fashioned guy. I like to go transgastric, but also transgastric will give us this angulation that we want. We want to be, I told you, 2 to 8. So probably we need to rotate slightly clockwise and go a little bit more anterior rather than septal. And probably pull back the old system just a little bit, just to be more in line. Okay, that is the angulation that I would like to have, if you agree, guys. We are nicely central. We are very close to this edge of the anterior leaflet. And with this angulation that we like to fix, I will also fix our X-ray Yes, I always like to use a wide as a first clip, because my target usually is to go to the most important, to the wider leaflet. Okay, so let's go back into, well, actually, we have such a good image here that I would probably cross like this the leaflets. I will give a bit of flex more. I don't want to go too much into the commissure. And I will stop somewhere here, open the clip arms so we see them better. Can you do an X-plane here? Just to see how deep we are. We are too deep. I pull back a little bit. I don't want to touch the papillary muscles. Okay, we are very nicely here. And I'm tempted to grasp in this projection. Everybody's using the inflow outflow, but this projection is very good for us today. So I would stay here. I think everybody who is doing tricuspid should learn how to grasp in this projection, because it's really very much controlling everything. We will check also in the other projections, but in principle, this is the projection that shows us. So we have the anterior leaflet, as you can see. I can see the restriction of the cords of the anterior leaflet. I'm not sure about the septal. But I will stay here now, and probably I don't drop the grippers. Let's go inflow, outflow. Let's have a look. But I think I have also the septal. Now I see that. I close the clip arms a bit more so I have control. I can see definitely the restriction of the anterior leaflet. We need to see if the septal is in. We wait for improving the image. Maybe the septal is not in. We'll see. It's not in. But it's not a big deal because we have actually a great image. So we grasp the, now the septal is easy to grasp, but the anterior is a bit running away.
Do you want to open the clip more?
Yeah, we can open the clip a little bit more, but obviously it's a double-edged sword. I think probably the anterior is in now. I don't see it well, but maybe it's in. So we have definitely the septal now. I can see it well, and we also have the anterior. This picture shows perfectly the two leaflets there. That's why I would like to drop the grippers, close a little bit. Yes. And wait for confirmation. I would confirm the position transgastric if you agree, before we keep on closing. I'm not pulling too much. I keep a little bit of tension. So the orientation is the one that we wanted, you see. We are at the edge of the anterior subsegment of the anterior leaflet. We also have the septal leaflet was nicely seen on inflow-outflow. I think it's the right time to close the clip. You agree? Absolutely, exactly there. So we close the clip now. Maybe we go in the inflow-outflow, so we can check also we can keep color. Maybe we see what happens as we close. We can put the color maybe. Okay, I'm closing now the clip. And you see already that the central jet, which was the dominant one, is gone. Interestingly enough, there is a bit of a commissural one, which was not so visible before, but the main jet is gone. Let me just take a bit more of that, because honestly, we had a fantastic septal, but we can probably improve the anterior. Let me try. Let's open. Yeah, open with the gripper down. I think I should go a bit more lateral to change the angle and get more anterior if possible. I will open now selectively the anterior, this one. Huh?
Yes.
The anterior gripper is up. I go slightly anterior and try to grasp more. Drop the grippers and close again. This way I maximize. You see now the anterior leaflet is shorter than before. Let's see the effect on TR.
The vein pressure comes down.
You see now that I think the overall reduction of TR is more sensible. Okay, again, I think as usual in these procedures, there are a lot of confounders until we are attached to the delivery system. I would check final arm angle and release this clip and assess the valve without the connection to the delivery system. So we'll check if the final arm angle is stable, which is the case. So as usual, it's releasing a bit of tension. And the clip is released. Okay, now, so this is the result after one clip. Pretty stable, yes. And the result is not bad. There is a tiny jet coming from the commissure. Let's make an analysis of all the components. The clip is exactly where we wanted. at the edge of the posterior part of the anterior leaflet. And obviously, you have the other component of the anterior leaflet, which is still open, and probably there might be a little bit of jet there. It's not too much, but you see there is a little bit of a jet there. The challenge here is that now we have still 3 leaflets there. It's not one. It's not the typical clover. If we want to do something, we still have, we still have 2 leaflets plus in front of the remaining septal. I also think so. I would not touch that area because it's too complicated. Actually, we already have ready a XT as a second clip because whatever we do now is going to be in an area which is small environment. So we have no much space. We decided to use a XT wide because we were targeting a wide leaflet. If there is a need for another one, if we believe that we need to put another one, we will do it with a smaller size. By the way, the patient now is hypertensive, is increasing the systolic blood pressure for some reason. I think he's telling us that the patient, he likes to have less TR. There is a tiny regurg from the commissure. I am really tempted not to do anything else. Well, not easy. So the challenge of going into the commissure is only that we don't really see the exact mechanism of regurgitation. It's not difficult because, after a while, after all, you just have to put a clip in the middle somewhere and close the remaining gap. So probably it's not that difficult. We can do that. I don't think it's impossible. I do it only if Eustachio tells me that the vena contracta is above 3 millimeters. So I give him a number. If there is still a moderate TR coming from there, probably we should address. The other challenge, probably technically speaking, you see the septum is really in front of it. Yeah. It's not easy. How much is the vena contracta? 0.6. So it's not insignificant. Obviously, it's a linear jet, probably is a bit overestimated.
Thank you very much. Such a very fantastic case. And Dr. Mazzano, can you tell us more about the decision-making process afterwards? Do you think this is acceptable for just one clip? And for experience, sometimes one clip, because already make a very good result, but did you put in a second clip, or what are the kind of decision-making process in your mind? Can you tell us more?
So in sake of time for this webinar, we are only showing the first clip. Actually, we position a second clip. Let's say the second clip, you have to decide whether you want to go into a clover technique to address the main component of tricuspid regurgitation. Don't forget, you are working in an environment with general anesthesia, and therefore you may underestimate the TR at the end of the procedure once the patient is awake. So in most of our patients where we operate in ideal conditions, but they have wider jets prior to the procedure, we tend to go for a second clip in the posteroseptal commissure. Now, in this particular case, you have a posterior leaflet which is divided into 2 halves. So a second clip in that position could be less effective than in other patients, although you can also expect some annular reduction by a second clip in the posteroseptal line of coaptation. The other jet that you have seen in the commissure, I think it was a little bit overestimated. The commissure has been already closed. Vena contracta of 7 is what you see in the line of coaptation. If you look in the perpendicular line, probably is a very linear and very small jet. I would say probably better not to touch. Actually, we didn't touch that jet. That is a little, if you do the 3D vena contracta, would be much lower. So, but again, your question is related to the decision making. It's a very complex decision making. If it is complex in mitral, in tricuspid is even more complex. And my answers are always a little bit opinionated. We don't have enough data yet. I think you need to always have few things in mind. Number one, avoid tricuspid stenosis. This can happen if you clip most of the anteroseptal and posteroseptal line of coaptation. You can create a reduction of opening. Number two, you should not only target tricuspid regurgitation, but also annular reduction. You know that each clip, and you have seen the optimization of the anterior leaflet insertion, the only reason to do that is not only to improve the durability of clip implantation, but also to achieve some annular reduction. The other important issue here is to interpret the line of coaptations. You need to identify, if possible, the chordal-free zones which are present in the middle of each leaflet. That is the challenge. For mitral, it's very simple. You go in the middle, A2, P2, you find no chordae. In the tricuspid leaflets, you need to interpret mostly what you see in transgastric. You can use a couple of landmarks. One is the septum and probably the aortic valve sometimes, where you can identify the septal leaflet and the anteroseptal commissure. And the other very important landmark to orient yourself is the papillary muscle, where the anterior papillary muscle actually divides the anterior leaflet component from the posterior leaflet component. And that is very important to discriminate between patients with 4 leaflets who have 4 leaflets because of 2 posterior leaflets or 2 anterior leaflets. Actually, the 2 anterior leaflet is a very bad combination usually. It's very difficult to achieve good results.
Yeah, thank you very much. And I would like to point out that now we have a very good discussion in the chat session as well. And thank you, Dr. Kubo, to help us. And I would like to take this opportunity to ask, for example, Dr. Hayashida, for sometimes we need to prepare our patients for the procedure, and we encounter patients with a really wide coaptation gap. And do you have any tips and tricks on how to optimize the patient before the procedure so that we make life easier during the procedure?
Thank you very much, Simon. Actually, the fluid control is quite important before procedure, especially the patient have the really severe or massive torrential TR. And if the patient has too large coaptation gap, it makes the procedure more difficult. And I think the fluid control by diuretics before procedure is quite important. We can also control the ventilation situation to minimize the gap in the of the tricuspid gap.
So Dr. Lozano, do you have any tips and tricks in handling patients with very large coaptation gap? Sometimes they may not have good imaging because some in challenging scenarios, the gap is very wide, the leaflets are not easily be seen. During the procedure, do you have any tips and tricks how we could address those patients with a very large gap?
Yeah, so first of all, these patients should be treated very carefully because you may have suboptimal outcomes even if you achieve coaptation, if you achieve a good grasping. Unfortunately, if you have a large coaptation gap, even after the procedure, in the next days, you may have some leaflet detachment. So don't forget that there is still some limitations for edge-to-edge repair in tricuspid. Anyhow, in many patients, we push the limits. Obviously, very important, probably the most important is prehabilitation. 2, 3, 4, sometimes 7 days of diuretics and some often also inotropes are very important. Many of these patients do not tolerate high dose of diuretics. This is the problem. So what we do during the procedure to optimize coaptation, you can use inotropic support. I like it a lot. You can put the patient in anti-Trendelenburg position. You can you can reduce venous return by using some PEEP on the ventilator. So there are many potential tricks to reduce, at least temporarily, the venous return and improve coaptation. But again, one word of caution: if you push the limits, you may encounter trouble. Patients with large coaptation gap, they have a risk of single leaflet attachment, and they have a risk of leaflet tears. So my recommendation, at least when you begin this process, and Japan is starting now, try to be selective. There are alternatives to TriClip, and we should refer to some rules. There is no magic number. We publish in PCR focus group the state-of-the-art algorithm where we put 8.5. You see 6.5 in other cities. Somebody says 10. I don't think it's a number, just a clinical judgment.
Thank you. So the next part, we'd like to discuss about the post-operative management. Can I ask Dr. Izumo,
Yes.
in terms of medication, how would you suggest for the patient to give antiplatelet or give anticoagulation? And in terms of echo follow-up, how long we should continue monitor the patient, and what are kind of interval between each echo?
Yeah, thank you very much, Simon. Of course, changes in severity of TR is very important, but not only TR, but also right ventricular functional changes and left ventricular morphological changes are also important. And functional status or QRS score is also important despite of the residual TR severity. And it is also important to improve organ failure, organ function. So TR reduction can improve liver and kidney function. And also we can reduce the diuretics after the procedure. I think total management is very important for this kind of procedure.
Yes. So Dr. Hayashida, do you have any suggestion on anticoagulation or antiplatelet treatments for this patient? And as in the case, is a patient with mechanical MVR, he will be given morphine anyway. So is there any specific protocol in the hospital that can guide the decision making for how to treat a patient with like antiplatelet, anticoagulations?
Thank you very much, Simon. Actually, I think that there is no robust data to support any guideline. And if the patient have atrial fibrillation, of course, we need to start the warfarin or DOAC. If the patient doesn't have the atrial fibrillation, sometimes we give only a single antiplatelet therapy, but not based on the robust data. So we need to have the more and more data, especially in our Asian cohort who have the higher bleeding tendency compared to the Western people.
Yes, that's a very good advice, and I think it's really based on the individual institutional protocol and patient-tailored made therapy. So I think sometimes we reduce the TR maybe to a small extent, but the patient received clinically actually improve in terms of symptomatology and quality of life. So really very important therapy for our patient, especially in the Asian population. So we have a very good discussion both online and also in our chat session. And thank you very much, Dr. Mazzano, Dr. Hayashida, Dr. Izumo, and also Dr. Kubo to help to bring this session to be a very fruitful and enjoyable session. And I would like to pass the time to Dr. Hayashida to close the session for today. Dr. Hayashida, please.
Thank you very much, Simon, for the very nice chairing of the session. And I also would like to thank all the attendees who joined this session. And first of all, tricuspid valve is quite complex. Sometimes it's 4 leaflets, not 3 leaflets. That is quite impressive for us, and we need to learn a lot. And we need to learn a lot about the anatomy as well as the physiology to treat this kind of patient. And imaging is quite important, as Masaki demonstrated. We also need to understand the anatomy by imaging. And the very high quality 3D imaging is quite important to achieve the best result for the transcatheter procedure. And now transcatheter edge-to-edge repair for the patient with tricuspid regurgitation is emerging as quite important procedural option, even in our Asian cohort. We also need to know the specificity for Asian patient. So we need to continue to publish the data from our country. And now, so we have the fifth webinar of the PCR Tokyo Web 2022. The next year, we're going to have the on-site meeting in Tokyo in February in 2023. And you're most welcome to join our meeting in 2023. And hopefully this webinar is quite fruitful for your daily practice, and see you very soon in the next year in Tokyo in 2023.